itself around AI and kind of where we might be heading in the future through some of the work that I've been fortunate to be able to be involved in. So here we go. So Helen mentioned this task force, and a lot of it stems from the government's approach to try and make sure that we do innovation in a good way. We were very pro innovation. We change things, we do things better, but we also do that safely. And there was a paper that was published by the Department of Science, Innovation and Technology that went through this in terms of the ambition for AI for the UK, in terms of being a world leader in this area. And in 2019, in the NHS, we started to look at artificial intelligence amongst other technologies that I talked about earlier in my talk earlier in the day, and in terms of how they're going to impact the healthcare workforce of the future. So what technologies are we going to be working with? And then AI was formed a significant part of those top 10 technologies that we expected to impact, of which you had speech recognition and natural language processing, which kind of fits within that. Automated imaging interpretation. You've seen some examples from Matthew. The role of predictive analytics using AI as well. And it was projected that many of these technologies would be quite far away, but not that far away. So we're talking about 10 or 15 years until they're kind of in large scale deployment, if you look at this image over here. But then the pandemic happened, and also various other initiatives happened, and there was a lot of investment in artificial intelligence by the government and by the NHS, and to think about how we do artificial intelligence right, but also what types of technologies actually exist and what types of technologies do we need to be looking at. So there was a series of awards that was put out over 3 rounds to invest in and support some of these growing technologies that are looking at healthcare. That might be at a very early stage, kind of prototype stage, all the way through to being able to be scaled at a regional level. So being able to be used in one region and building the evidence around it. And some really interesting technologies were funded in this space. So a really good example is something called Brainomics. Brainomics is a technology that allows you to look at stroke imaging and make faster decisions around stroke imaging so that you can make quicker decisions to treatment. And now many of you will know that for stroke patients, it's time critical that you make a decision on their treatment, particularly if you're going to choose to do thrombolysis. So if you're going to have a treatment where you help to thin their blood and treat the clot that's formed in the brain. And therefore, having a technology that allows you to look at the image in a more efficient way, working with a radiologist to make decisions quicker, is significantly improving patient care from what we've seen from the evaluation. And then I'll talk a little bit later about some of the other approaches that are being taken now going forward. So as a result of the TOPL review and the work we've done at Health Education England before, we decided to start to do a bit of a stock take and say, well, where are these technologies at the moment? How are they impacting the NHS? What areas do they sit within, and what their spread and adoption? And also, how might they affect the workforce of the future in more detail? So we published a report that's out there that starts to unpick some of this, and we found that the majority of the technologies in this area, unsurprisingly, are in the diagnostic space, and it's why Matthew used that as a really good example, because we know that's where the maturity lies. That's where the technology is in its most capable form to be able to pick up pattern recognition and be able to pick up and diagnose images. But also other diagnostic tools that can be used for things like diagnosing of risk for chronic kidney disease through urine samples was one of the technologies, or ECG evaluation or echocardiogram evaluation. So you're seeing other diagnostic tools also enter. I talked a little bit earlier about robotic process automation, and I talked about unassisted and assisted robotic process automation, but you move towards intelligent automation as well. And we know that can help to improve some of the efficiencies that we see. So we found a group of technologies in this area. What really interests me is this area over here, remote monitoring and P4 medicine. So P4 medicine is participatory, preventative, predictive, and personalized. So technologies that allow you to do truly person-centered healthcare and population-driven healthcare. And remote monitoring is, of course, the types of technologies that allow you to treat people in their home environment. And we saw a big rise in those technologies as a result of the pandemic, particularly around respiratory services. You know, people have pulse oximeters at home. You can give them blood pressure machines at home, and you can collect information and support people at a distance. These group of technologies are going to be essential because we know we have a growing population. We know that we have growing demand for healthcare services. So if you can keep people healthier in the community and support them better, then I think we will achieve a more sustainable healthcare system for the future. So that group of technologies around P4 and remote monitoring are technologies that really interest me. And in the small areas, therapeutic technologies. And again, I talked earlier about CBT type technologies that can be used to deliver treatments from a therapeutic point of view. I talked about this before, so I'm not going to repeat it, but I am going to tell you about where we want to get to. So in 2019, when the Topol review was published, Eric Topol described a personalized, rationalized, tailored to the individual healthcare system that uses the intersection of genomics, data, artificial intelligence to be able to do that. And we know that we practice evidence-based medicine, and we're very good at practicing evidence-based medicine. But what we want to do is we want to get to precision medicine. We want to be able to do medicine that's tailored to people, that meets their needs and suggests the right thing for them. To get there, we need to now move towards intelligence-based medicine. So we need to build on an evidence base and build on some of the information and the real world data and population health information that we have out there to be able to get to this point. But that will take some time, and that will take time to move along some of these curves. So there's a curve that was described that's called the data, information, knowledge, intelligence, it's all the way through to wisdom. And what that basically means is we've talked today about some of the types of data that exist out there, from structured to unstructured data, to all of that stuff that sits within our electronic healthcare records, or sits on our NHS app or wherever it might be. And that data allows us to provide certain level of information. It gives us information that then we tie together to knowledge that says this might be your diagnosis, etc. But we want to move towards intelligence, as I described. So we need to move further down this curve. And then eventually, when you get intelligence, you also move into something called wisdom, where you start to actually make decisions based on the future. You start to take further actions. And the other analytics curve to be therefore aware of here is this: descriptive, diagnostic, predictive, and prescriptive. We're at this stage where we're very good at descriptive. We're very good at being able to visualize, look at data. I can look at a healthcare record. I can say this is someone's blood pressure, this is someone's heart rate, etc. And we can turn that into diagnostics. We can turn that into why are things happening. We can say, well, this person is having this because they're at this they have a Q risk score of 12 or 13%, so therefore they have this level of risk over the next 10 years of getting cardiovascular disease. And that allows us to slightly move towards a predictive space. Where we are not is truly in the predictive space and truly in the prescriptive space. Now, I've been lucky to do some work locally within one of our integrated care systems that you heard about earlier in Sussex, to develop their integrated data set, to pull all of that data together from community, from hospitals, from GP surgeries, from local authorities, and start to look at that data at a kind of a global level for that population of however kind of many million people. It's about sort of 3 or 4 million people, or 1 or 2 million people, and also then look at specific use cases. So we know in Sussex people are more likely to fall because they're quite an elderly population, and therefore people are more likely to turn up to A&E or end up in hospital with injurious falls, so hip fractures or whatever it might be. And so now what we've done is we've been able to build a model that allows us to predict who is going to be at highest risk of developing a fall. That allows us to do that with anonymized data in an integrated data set. But what we want to then go and do is say, well, what can we do? What information can we give to GPs? What information can we give to other community services to say, these are the risk of your patients that are higher risk, and these are the types of things that you might be able to do to reduce their risk of falls. And that's when you start to move into that predictive and prescriptive territory. And when we get there, I truly believe we'll transform the way we deliver healthcare. So as Helen mentioned, there's a task force that's looking into the role of next generation of AI, and there's going to be a safety summit that's being held at Bletchley Park in November, which will start to unpick some of these challenges by working with academics, with policymakers and leaders and politicians and domain experts like Helen from a healthcare perspective to come together and try and plan for how we're going to do this properly and safely and responsibly in the future. And I'd like to tell you a little bit about some of the work that we've been doing with responsible AI. So we've been starting to think about how we educate people, and this is a great example today, doing a generative AI workshop in the afternoon. And thank you for Trustwise for supporting us with this, but also thinking about how we apply and innovate and how we create new changes and practice some of the work we do, as well as advocate for the right changes that need to happen in policy. And that we're doing that some of that work to date in terms of regulation and guidelines. And the innovate areas where I'm really interested. We know that actually technology works in the NHS when it's been co-designed, when we brought the right people together. So you brought patients together, you brought clinicians together, you brought other NHS staff together to try and define what the problems are and then try and define what the solutions are. And we're going to have a go at that this afternoon. We're going to play around and we're going to have some fun. And I'd like to give you an example of something that we did as a result of a piece of work that we did at locally within Kent Surrey, Sussex. So I've talked about this, but I'm going to move on to this, which is we published a report called One Size Doesn't Fit All. Now, if many of you are familiar, if you get your medication prescription, you take the medication home, there's a leaflet inside that box that tells you all of the information about that medication. It tells you its side effects, it tells you its interactions, it will tell you how to take the medication in an appropriate manner. We did a piece of research to start to actually go and listen to people and understand what they thought about these types of, this type of approach to providing medicines information. And we found that only 32% of patients said they fully understood their medicine information leaflet. We know there's a significant challenge in the population around digital literacy, but also health literacy. And a lot of people are reliant on asking for advice from the healthcare professional. And I remember having cases where patients have been prescribed the medication but not felt comfortable to take it because they're still unsure about certain side effects, or they're still unsure about certain interactions that they wanted to go back and check either with myself or a pharmacist or another healthcare professional, but then didn't have the ability to go and have that access to that individual, and have waited maybe a month or two before they've followed up with me and told me, no, doctor, I didn't try that medication yet because I was worried about this. So clearly there is a challenge in terms of how we provide the best information, the most accurate information to people in a way that's intuitive, that's accessible, and that's understandable. And we know that the average reading age, for example, for the population is 9. So we need to provide information that is digestible for people. And we know that a lot of the patient information leaflets that we have available to us already do this. So being able to pull some of that information together would be really interesting. So we had a little bit of fun with Trustwise, one of the companies that we're working with at Health Innovation Kent Surrey Sussex, to try and test this out and see what this meant for something like medicines information. So there's a platform called Hugging Faces, which allows you to compare 2 types of large language models. And what we did on there is we took a data set, and this afternoon we'll show you about kind of the places that you can find some of these data sets. And we compared a kind of an untrained model without any kind of safety aspects put within it or guardrails put within it, compared to something that had some guardrails put within it. And we started to think about the types of misinformation or things that would come out of it if someone started to ask it questions. And the data we fed it was kind of open source data based on medicines information. So it's global. Therefore, some of the terminology is obviously global. As you can see, acetaminophen, which is another word for paracetamol over here. But we also did start to pull in some NHS leaflets. So we started to pull in some NHS leaflets, particularly for patients that are recovering from liver transplant or other types of services. And we pulled those into these models. So we kind of just threw them in there. And then we started to look at what comes out. And we asked it some very simple questions like, what is the recommended dose for paracetamol, acetaminophen, whatever it might be? And as you can see, with the model that we didn't put any guardrails to, you can see that actually it says to give a dosage of 1 tablespoon a day. Whereas actually when we did start to apply guardrails, it started to be much more accurate in the information it gave. It said, this is the dose of the medication, this is how many times a day you give it, this is the maximum amount you give it. And this is the recommended dose, which actually is a relatively accurate information. They then asked the question, well, what if I don't have this medication? What do I do instead? And then actually the untrained model started to say, well, go and have codeine, which actually isn't a terrible suggestion, but is probably is probably not the appropriate suggestion for a self-care tool to be giving. A clinician might give that advice if it is appropriate. So there is a certain level of misinformation there, but again, it was trained a little bit more with some guardrails and safety and NHS leaflets. It was able to say, actually, you can take ibuprofen or naproxen. Now, again, there's a challenge there because naproxen needs to be prescribed, but something like ibuprofen is something that you could go to a pharmacy and get over the counter. So slightly, again, better information that comes back from it. And the final thing we did is with this liver transplant. So we fed it the leaflets around liver transplant, and we said, what are the recommended medicines for a person that just underwent a liver transplant? And they recommended a couple of medications that were not really very clear why, and also I'm not convinced that, I'm not being a specialist in the area, I'm not convinced that would be the types of medications that you would give immediately after liver transplant. When we compared that to something that had been fed some of the right information, the right leaflets, and had the safety around it, it was able to give a little bit more advice that is perhaps a little bit more accurate. So advice around kind of treatment in terms of immunosuppressants and also antibiotics and anti-nausea medication. But regardless, this shows the risk as well here, because actually this is information that should be given by a healthcare professional, shouldn't be given by a tool like ChatGPT. So again, this experiment showed us, one, the risk of not having guardrails in terms of the quality and the correctness of the information. But also, even when you do have guardrails, there are certain questions that you probably don't want it to be feeding back on, and actually should be signposting you towards a clinician. So that's a little bit of a test that we did, and then I thought I'd just share that with you, and you can see some of that in more detail over here. So this was the model that had not had any guardrails attached to it, and then this is the responses once you do attach some guardrails to it. Much more information, much more detailed, and much more clearer. So that's me. I'm going to stop there, but it gives you a sense of some of the possibilities in this space.